Yep, we're ready.
Thank you. Morning everybody, and welcome to Health and Wellbeing Board, Friday the 14th of March. We do look a bit thin on the ground, but we are quorate, so we can crack on with the business. So welcome everybody. I just wanted to mention before we started that obviously people will have heard around what's happened with NHS England, and that must be really shocking for the staff that work there. And obviously there's going to be impact on ICB. So I just think that it's really important that we acknowledge that change today, and we will be as supportive as we can going forward around how those new services look in the future, and and how those staff are looked after. So I just wanted to acknowledge that before we started. So if we can just go round and introduce ourselves. I'm Councillor Jane Slater. I'm the Exec Member for Healthy and Independent Lives.
Gareth James, Deputy Place Leave, NHS Greater Manchester and Vice Chair of this board.
Heather Fairfield, I'm the Chair of Trafford Health Board.
Hello everybody, I'm Councillor Jane Brophy. I represent Simply North Ward. Next year I'm Mayor, so this will probably be my last meeting.
Thank you for attending, and thanks for your contributions over the year. So thanks, Jane.
Hello everybody, I'm Councillor Karina Carter. I represent Davyhulme Ward, and I am the Executive Member for Babies, Children and Young People.
Good morning, I'm Jane Waring. I'm a GP in Impton, and I'm here on behalf of the GP Board.
Good morning, Jo Sherratt, Chief Exec, Trafford Leisure.
Hi, I'm Claudia Cohen. I'm one of the Public Health Registrars with the Council.
I'm Georgia Thurston. I'm Democratic Officer.
Councillor Dylan Butt, Chair of Trafford Health Scrutiny Committee.
Morning everyone, Tom Maloney, Programme Director across Health and Care for the Council and NHSGM Trafford.
Morning folks, Adam Hepton, Interim Director of Strategy for MFT.
Hi, Richard Spring, Managing Director, Trafford LCA.
Hi, I'm Bernadette Ashcroft, Chief Officer for Trafford Community Collective.
Hello, I'm Rose Thompson. I'm a councillor for Brooklands and the Exec Member for Communities and Safety.
Good morning, I'm Helen Gollins, Director of Public Health at Trafford.
Thank you, everybody. And I have to leave early today. I'm going to a funeral at 12 o'clock, so Gareth is kindly going to chair the end of the meeting. So if we can just note the absences. Do you want me to read them?
You've got, if you want.
Yeah, thanks, George.
So we've received apologies from Sarah Todd, who's Chief Exec and Place-Based Lead, Councillor Eckersley, who's Shadow Executive Member for Healthy and Independent Lives, Maggie Kufel, Interim Corporate Director for Adults and Wellbeing, Caroline Davidson, at MFT, Liz Murphy, Chair of Trafford Joint Safeguarding Board, Graham Ferguson, Deputy Associate Medical Director, Liz Calder, Director of Performance and Strategic Direction at GMMH, and our representatives from Greater Manchester Police have also sent their apologies.
Thank you, Georgia. So if we can move on then to item 2, it's the minutes of the last board. I think that we had a very good board last time. I think there was a lot of debate, and I think a lot of stuff came out of that. So if we can just quickly have a look through the minutes for accuracy. If we can look at pages 1 to 8 for accuracy, are they okay?
Yes.
Are there any matters arising from those minutes? Nope. Thank you very much. So we will agree those. Are there any declarations of interest? Item 3. No, thank you again. And then if we can move on to item 4, GM Live Well, and that will be a double act from Helen and Tom. So is it over to you, Helen? And unfortunately this morning we've not been able to get the technology to work. So if you can have a look at the papers on your laptops if possible, and if you haven't got a laptop, if you don't mind sharing with the person next to you. Thank you.
Thanks, everyone. So we felt it's really important to bring the GM Live Well model to Health and Wellbeing Board. So it's still in discussion and still very much in development, but it really kind of speaks to the Health and Wellbeing Board and our kind of objectives and priorities. I'm going to do Chris Whitty, so it's quite tricky, isn't it, with the moving slides on business. So the GM Live Well is Andy Burnham's commitment to public sector reform at a community level. So he states that the goal is for everyone in every community to have daily access to support and advice to improve their physical and mental health and social economic status, which is really important. And it's something, if we think about our most recent public health report, we talked about the building blocks of health, didn't we? And without those, it will be incredibly challenging to address health inequalities and you know, ensure that everybody in Trafford thrives and is successful. So this speaks really nicely to us as an organisation, and you know, helps us think very much around that prevention activity as well. So the model is moving at quite a pace, and it's just kind of understanding how we all link and how we all play into the model. So you can see that Live Well is joining up public services with our vibrant VCSFE sector, so looking over to Bernadette there, taking public sector reform further through an even sharper focus on prevention. And locally, we are really driving that forward. So we are developing a prevention framework, which we will bring to the board at the next meeting. It's going to the locality board for sign-off in June, and that is working collectively with our ICB colleagues and our adult social care colleagues in the first instance to understand what prevention looks like for our adult population. And when we talk about prevention, it obviously means different things for different people. In public health, it's about health creation. Prevention feels quite a negative statement, doesn't it? Because you're trying to stop something happening. Really, what we should be thinking about is how we, you know, support our communities and our residents to be healthy from the start without having to prevent anything. But there's a strong focus locally around that, developing the prevention work, which is brilliant. And a radical shift in how we work together with communities. So this is very much around our neighbourhoods and our communities to reduce health, social and economic inequalities. And I would say for Trafford, this isn't new. This isn't something we're starting afresh on. This is something we've been committed to for a very long time. And the GM Live Well is refreshing because it means that the whole system is thinking about it. But it also comes with its own challenges in terms of how we work this through and how we as an organisation as well ensure that we're all sighted on it at the same time, because it fits across, I think, every single directorate and every single service. So it's just some of those challenges. So what Live Well isn't, which is what I've kind of just said, is the reinvention of prevention work, because, you know, there's tons of stuff going on locally. It's not delivering on reducing economic inactivity, even though there's lots of that work going on at the moment, and we are in the process of just finalising an economic inactivity trailblazer for Trafford, which again we will bring to the next board. And it's not focusing on the single sector. So in terms of how this board thinks about it and how the locality board thinks about it, it is the opportunity is how we work together successfully to support the health of our residents. So if we move on to the next slide, you can see the components of GM Live Well board, and there's 4 of them. And I think it's quite easy to tick through some of these for Trafford. So the optimum neighbourhood model. So in Trafford, we have our 4 neighbourhoods, which have been developed on a footprint of between 30 and 50k population, and they are working really well in terms of the network. So the work that Bernadette and Adrian and Dan drive forward is brilliant. There's still work to do, obviously, and lots of thinking through some of the priorities and sustainability of some of the model. But, you know, I think Trafford is really far ahead in that. Last week, I went to a meeting at the GMCA around the optimum neighbourhood model, which is interesting using the phrase optimum. So there's still a lot of discussion of what that will look like. But I think in terms of Trafford, we are quite far ahead on that. Live Well centre spaces and offers, and there's a slide that kind of breaks them down a bit further. But obviously, as you know, we've got our community hubs in Trafford, we've got the Stretford one-stop shop, we've got the family hubs that are coming online and are developing. So there are centres and spaces that our residents and their families can access within the community. But again, it is just ensuring that they're sustainable and they're meeting the needs of the residents as well. Resilient VCSFE sector, And I know that Tom and Bernadette and colleagues are working closely around what the future kind of looks like in terms of that. But I would just say in support of all the brilliant work that Bernadette does with the Community Collective, it is brilliant in Trafford and it is a vibrant sector for us. And then that culture of prevention. So obviously I've talked briefly about the work that's ongoing around developing that framework at the moment. And what I would say as well is that when we've gone, and it's big pieces of work kind of doing the mapping of what we're currently commissioning, what we're currently spending, the doors have been opened. It's not been a difficult conversation. People in Trafford embrace the idea of working collectively and are really committed to improving the health of our population through kind of a prevention framework. So that's really positive. So that's the components of the GM Live Well model. And obviously we do have elements of it that we need to just strengthen and work through. But if we go through to the infrastructure element, these are the key kind of discussion points at the moment from the GMCA and from Andy Burnham's office. And it's around Live Well centres, Live Well spaces and Live Well offers. So I'm not going to read it all the way through because you've got it in front of you. But, you know, again, I think the Stretford Hub is a really good example of a Live Well centre. And again, this is something that was developed way before Live Well was even talked about. And it came out of the Community Hub, but also the Poverty Truth Commission, which is really important to note that the voice of our residents has led to the development of that Stretford Hub. We've got Live Well spaces, which again are about welcoming community-led places where people can connect and support each other and take action. And again, that doesn't need to be a functioning community hub in the way that we have established them. It could be a space, a cafe, it could be a leisure centre, thinking about the Partington development, for example. And then Live Well offers. So thinking about public health and the work we do with the ICB, we've got loads of joint offers in terms of support to our residents for specific health conditions, but also early intervention and prevention as well. But we know that working across into Richard's Place Directorate, there's lots of work ongoing around benefit advice, employment support and multiple disadvantage as well. So again, lots of things we can tick off, but it is just about aligning what we're doing to how GMCA and Andy Burnham are visualising what Live Well in Greater Manchester is going to look like. So I'm just going to hand over to Tom now.
Thank you, Helen. So last couple of slides, and hopefully that will stimulate some questions and debate at the end. So building on what Helen said, I don't think any of this is radically new. We've been doing this in Trafford in many guises and calling it different things for many years, as have all the localities across Greater Manchester. So we build from our strengths, and Helen's alluded to a number of those, the vibrant BCFSE sector that we've got, the community hubs that were established as part of COVID that have gone from strength to strength and have grown their role and importance within that place-based approach. So we have a signed off locality plan that waxes lyrical about how important it is to work in neighbourhoods and how important prevention is if we're to sort of turn the dial on outcomes for Trafford residents. We've got our neighbourhood programme that myself and Richard work very closely on, along with other colleagues in this room here today, and a really live conversation about how we make neighbourhood working and prevention the default, as opposed to a collection of projects, but actually it's the way we work in Trafford. So there's a strategic set of conversations happening in different forums around what that would look like. And to help fuel the debate in that conversation, we're behind the scenes, we've just started through the Provider Collaborative Board a self-assessment against some of what Helen and I and Mitch, who's contributed to these slides, who isn't with us today, unfortunately, because he's on annual leave. But we drafted a self-assessment template, a little bit dry, but just to try and establish a baseline of where we think we are in Trafford against what's described within the GM Live Well documentation. And that will prove, I think, really helpful for the next set of conversations that we need. Interestingly, there's various pots of seed funding to try and mobilise some of this work, noting that we're all in slightly different spaces across Greater Manchester, all with our own assets and areas of good practice, but it does really vary, which goes back to that point around the model neighbourhood, picking the best bits from each of the 10 to think about what that gold standard would look like. I do think we have to test ourselves, though, here in Trafford and say we might have prescribed way of what a model neighbourhood would look like, but it's got to be right for us here in Trafford. It has to build from our ways of working, and it can't just be a default GM document that says this is what you must do and achieve. We've got to shape that ourselves, and hence the importance of the conversation here today. So there are various pots of funding that are coming through the system, some of them very small, and you'll hear about that some of later on in the agenda through the long-term conditions work, but there are other pots of funding going directly through the community collective back out into the VCFSE sector to do community-based interventions. The problem with some of that is it's very bitty, and we've got small bits of funding coming in at very, very short notice. And actually, if we step back through this exercise, I think, around self-assessment and understanding our desired model, we might be able to be a bit more strategic with that investment when it does land. And we'll keep banging the drum about how we can get a more significant settlement with advance notice into the NHS GM and GMCA centre. So we'll bring back further updates to the board on some of the funding that will be attributed to this to hopefully accelerate the work. We've got great opportunities in the coming weeks and months ahead. We have a Trafford Partnership Summit where this will be a focus of the conversation. So that provides a real whole system, so broader than just the Health and Wellbeing Board and broader than the Locality Board membership, but engaging our education partners, our private sector partners, to have a conversation around the opportunities around GM Live Well. We will build on that neighbourhood programme I've alluded to. We've had great successes over the last 18 to 24 months on that, but we know we've got areas for improvement. We're doing a lot of work in the integrated neighbourhood team space. We're doing amazing work in the neighbourhood network space, but there are some opportunities that I think we need to grasp, and that will be dependent on the level of commitment from partners in this room and outside of this room to make that work. I'll just use this as an opportunity to plug that we are going to have a Health and Wellbeing Board and Locality Board joint symposium in early June. I think that'll be a fantastic opportunity for us to think about the level of appetite and aspiration that we've got amongst partners to really commit to this. So really looking forward to that, and we'll obviously come back to the board and brief you on what that agenda and the purpose looks like in due course. It's very early days, but I think we've just nailed down the date to meet. Helen might want to come back in on this, but in terms of fairer health for Trafford, making sure that health inequalities lens is completely embedded throughout as we're having these conversations and as we form our version of Trafford Live Well. So some real practical next steps is we need to understand where the governance sits for some of this, because it is one of those things that crosses so many different boards and forums, and everyone has a role to play within this. So we do need to think through, have we got the right people in the room to contribute to these conversations and shape the work and take ownership of the work, whatever it is that we agree. We'll continue with the self-assessment, and we'll open that up to this board and lots of other different partnership forums once we've had a draft go at placing in some content. Mitch has put within this slide here around the importance of understanding and mapping our assets. I'm not too sure we've got that in a sort of central repository, so I think that's really important to understand the assets from which we will build our model moving forward. So we're not reinventing the wheel and thinking about how we can have a flagship Live Well centre when we've got 6 vibrant community hubs that are delivering some amazing services for local people. So it's how we frame some of those conversations. And then continue to work with GMCA and NHS GM centrally to understand the implementation and next stages of this, to make sure that any funding that does come through to mobilise some of GM Live Well's ask that lands at an appropriate time, that aligns with our strategy, and we can deploy that in the best way we see fit. And I probably think that is where I'll finish.
Thank you. I think it's really interesting work that we're going to be looking to do going forward, and I think that it feels like we're going to have community back in our areas. That actually people are looking out for each other, people are caring about each other. It feels really, really good step forward for us, and obviously, I know when I speak to residents, they want things close to home, and this is going to be that opportunity to be able to get the support they need. And I think that when he talks about mapping the assets, we've got loads in Trafford, and I just don't think that sometimes we shout loud enough. And I think that it's really good that we've got some really good voices around this table that will be able to feed into that GM model for us going forward, because sometimes it feels to me when I go to GM that people try to sort of like quieten the voice of Trafford. But no, I think it's really good that we've got a good group of people that are going to be able to challenge and make sure that Trafford is in the room and that Trafford can actually get what it needs for our residents, because we're a very different borough. You know, we have some pockets of real bad deprivation. We have pockets of where people life expectancy is so much shorter than in other areas of Greater Manchester, and we need to be saying our people matter, and I think that this is the way that we're going to be able to get in on that conversation. So thank you, Helen, and thank you, Tom. It's really, really good work. And what was the other person's name? Mitch, sorry, and Mitch as well. You know, thank you for the work that you've done. Are there any questions? Gareth, Jane, go next.
Yeah, thanks. It's not really a question, it's more of a sort of statement and then a request for the next meeting. So I think this is a really helpful summary on 4 or 5 pages. It's really confusing sometimes, isn't it, to understand all of the various programmes, pots of money, and it makes my head spin sometimes. And yes, so seeing this and what it means for us in Trafford is really, really helpful, and is absolutely, you know, the right conversation we need to be having. I think for the next update we do, it'd be really helpful, and we've talked about this a lot, Tom and Helen, is having a really simple summary of all of the different descriptions, all of the things we've got going on under the broad banner of neighbourhood or live well model. I think that'd be really helpful, and to understand the money and what we're going to use that for, I think would be really good focus for next time, and for that joint meeting actually with the locality board. I think because, you know, that joint ownership would be really good. But thank you, you know, it is great.
Councillor Brophy.
Yeah, thank you for the reports. I recognise it's quite top level and there's a lot that happens underneath the framework that you've got. Also, it's about funding as well from Greater Manchester. But my point is the neighbourhood model, working with people, and your local councillors are definitely, especially in Trafford, I think more so than across other parts of Greater Manchester, our local councillors are actually very engaged with the community, very tuned into what's happening. So I'm sure they'll be part of this. So just asking you how the council is going to be involved. Second one is the faith organisations in Trafford. They're very, very strong, the faith organisations. A lot of this happens through those faith organisations. So that's the second question is how will they be involved in this new initiative?
Shall I just let Tom come back in to answer Councillor Brophy, and then, or did you want to comment on that as well, Richard?
I can answer the question.
Oh, brilliant, crack on.
Please add then, Richard. So I think really 2 really good questions. So I think we have local councillor engagement in all of the neighbourhood networks, and I presume that was what Richard was going to say. So they happen bi-monthly in each of the 4. We've just, again, as a bit of a plug, next Monday, we have, a week on Monday, we have a joint West and North joint neighbourhood network session to think about the future of the neighbourhood and have a conversation around the future of what does GM Live Well mean for Trafford. So really well engaged from a neighbourhood network perspective. We also have a session in the making for local councillors around the strategic reset of the neighbourhood model as well. So that's a day that's just going into the diary. And I know Rose and Jane and Karina, you've been approached for some availability. There's no reason why we can't schedule a wider conversation there with elected members outside of the exec. So that we'd be more than willing to do that. In fact, it'd be extremely helpful. And then just in terms of faith, I know Bernadette might want to come in on this, but I know that some of the faith organisations are truly integrated into delivering certain aspects of the neighbourhood action plans in each of the 4 areas. We hosted the South Neighbourhood Network, I'm going to get this wrong now, but the South Neighbourhood Network, Bernadette were represented, I can't remember which church it was. Yeah, Divine, that's it, sorry, yeah, simply. So again, really, really good engagement from the faith sector within the model.
I've got a couple of points to make, but to support the answer to that question, I mean, Altrincham Baptist Church is one of the community hubs, as is St John's, which is also faith-based. And I know that the Hope Centre in Partington, Ruth Ramsey, that's very much aligned to faith groups in the church and the ministry kind of thing. So it's kind of there, and there's the F in the VCFSE. Which is very much, and we do work quite closely with those faith groups as well. So they are really quite embedded. But if it's okay, Chair, I'd just like to kind of this work is already undertaken. We've already had funding and used it from Live Well, from this department. Just, you know, I can't take credit for this. George Devlin actually kind of drew down £20,000 a year ago. 10 of it went to the Ageing in Place project in Old Trafford, which is going to now run until September, which is great news. And 10 of it went to the Sale More Partnership to do some fantastic work. So we've just now reported back on that into GM. So we've got the story of how that money was spent and the impact that it made. And only the last Friday I got confirmation, I got the grant agreement for £40,000, which is grant funding, which is going out into the sector. But we're all involved with that because it's sitting under the Fairer Health for All. So it's about kind of working together with that. And it is drip feeding money, but that drip fed money makes a big difference. That £10,000 has made a big difference to the Sale More Partnership and what Jamie Rennie can do out there. So it's really important, but it's small bits, but all those small bits make a big difference.
Thanks, Billy. That's really helpful. Sorry, Richard, it's you now.
I think the only other thing just to say, I think for us, which is the point that you were making, Councillor Slater, which is that the neighbourhoods are all very different, aren't they? And we started this work, and I think why it's been so successful is there was a kind of, well, do we do a top-down, or do we talk to the communities first? We started the work with the communities first and held our nerve on that. It took about a year for that to come through. And I think that's why we've got such robust arrangements really happening at a local level, and with the, you know, all the amazing support that Bernadette and the team are putting in. But that's the principle we're going back to, Tom, again, isn't it? Which is you were referring to. So we've got the event on Monday week in North and West, and we've got similar ones lined up in Central and South as well. So we're going to be talking to them first about what they think we need to do next. And so when we have the symposium in June, we will have their voices very firmly in the room. And I think sticking to that principle is really important, because that's the root of success for us, I think.
Councillor Butt?
I'm just wondering how it engages with the youth, the younger people. Perhaps you could just give some elaborate on that, please.
Happy to start, and others can jump in. So I think in terms of GM Live Well, it does feel more adult focused, would be my reflection so far, not necessarily honed in on children and young people. However, I think the work we've undertaken over the last 18 months to make sure that the children and young people's offer in the broadest sense, it has been integral to our neighbourhood programme. So the work around establishing family hubs, the family help offer is all being routed through that neighbourhood lens and coming through the neighbourhood programme steering group on a monthly basis, and through senior leadership in the council specifically. It's also integral to some of our dedicated programmes of work. They're based in neighbourhoods around what we refer to now as Changing Futures, which was the multiple disadvantage grant that we got from GMCA at the back end of last year, which is a programme of work working with those who have really complex needs and support requirements. So that's about to go live as well. So there is a real integrated approach there. I'm sure there's more work we can do.
Thanks, Tom. I think it's a really good point to raise, but we've got to start somewhere, haven't we? So this is the start, and obviously children live in families, whatever the family looks like, and we just need to be making sure that we're getting this off the ground and started, because what we don't want to be is behind. You know, we've got to be in front in traffic. Helen?
Just on the children's work, I know that at the moment they're having children from Trafford as well, so that needs to really reflect the work of Live Well and the neighbourhood in that as well. So lots of community engagement with our young people, which is really important.
Got my mic on, there you go. I just wanted to pick up on the symposium. So this is the joint locality board and health and wellbeing board event. It's going to be a full morning, but we're trying to do it innovatively to get some energy and excitement into the space, because there's a lot of exciting stuff going on. It's going to be at UA 92. We're using an igloo, which is a 360-degree filming space, so we're going innovative. This could be career defining for me and Tom, we're slightly concerned. But this is about, as the plan is for at the moment, is for services, individual services, to think about what this means for them, and then to bring those principles and that way of working together to say, actually, this is what we're doing, this is what we need to strengthen. So we're going to do it obviously with that strategic view, but also in quite a tactical way as well, so we can really work out some of the things that we need to improve. So do look out for it landing in your inbox and in your diaries, and it should be a really good morning, hopefully. So thank you.
Thank you, Helen. Any further questions, comments? Joe?
Just Helen, do you know what the date is?
Potentially. Yeah. Do you know how difficult it has been? It's like herding cats, but we think it's going to be the 10th of June in the morning. And if you're on leave, Joe, you've got to cancel it. Okay?
Yeah, I think it'll be a really good piece of work for us all to be involved in, and hopefully I won't be chairing that meeting. Hopefully it'll be the leader or Jane that will be doing that. Right. Thank you, everybody. That's been a really good discussion, and look forward to seeing the rest of the work coming out of GM Live Well. If we can then move on to item 5, which is Trafford's Sustainability and Delivery Plan, and that's going to be you, Tom. Thank you.
It's just a short intro for me now.
I didn't see you because my hair was in my eye.
That's fine. Just a short intro for me, then I'll hand over to Tom, who's provided leadership to this process. I think that Tom and I have given various updates on planning over the last probably year or two to the board, and conscious again, a similar conversation really, that the planning landscape can feel a bit confused and very busy pitch, isn't it? A crowded pitch, isn't it? So hopefully this report starts to clarify how that's coming together for Trafford and what that means for 25-26 and our part in the wider GM sustainability agenda. I think we've talked before that all 10 localities had to develop a delivery plan to demonstrate how we would support the sustainability plan that's been agreed for the whole of the GM ICS. So hopefully we're doing that now. Our intention has been, based on the conversation here, that it can feel a bit overwhelming, is to keep this as simple as we possibly can. So our approach that you'll see, it's on the first slide really, is just to keep this as simple as we can. So to build on the work that we did last year, 24-25, and that very detailed delivery plan of priorities that we had there, to agree anything new for 25-26, because things do move, don't they? But a smaller number of new priorities, including those of our provider colleagues. So for the first time, I think that they've been really embedded in our plans for next year. And then also trying to align this to the 5 pillars of the GM sustainability plan. So you'll see some really clever slides in here of how our plans are aligned to the GM pillars of sustainability, and ours are very much centered around prevention and proactive care, you'll see. So I think this year feels slightly different because we've got a wealth of data and information that perhaps we didn't have last time. So it's really focusing our attention where the need is greatest. As Jane said, certain pockets in Trafford and certain service areas where we know that there's greater need, and we really need to focus on moving forward. So I think that's a far more positive, having all that information. So Tom, can you just sort of talk a bit more detail of the process of being through and next steps? And then we'll pause. Thank you.
Thank you very much. Great introduction, Gareth. Thank you. Just to build on a few of the points that you've made, this was building on the approach that we embedded last year with, I'd say, a little bit more rigour and more involvement from stakeholders, which has been fantastic to see. My reflections will be, we've still got some way to describe some of the return on investment and outcomes for each of the individual interventions, and sat behind these nice colourful slides, which evidently are high level, is a spreadsheet with 100 rows in of things we're going to do or proposing that we're going to do next year. So if people do want a copy of that, more than happy to circulate that round separately. It would have been a nightmare putting that document into a PDF for the purposes of this meeting, and not meant a great deal to colleagues. So we tried to give a high level overview. As Gareth said, a lot, and this was the instruction from Greater Manchester, was we want to understand what your contributions are to reducing prevalence and proactive care. It's not to say that we're not doing things that aren't around cost improvement or system productivity, but the focus of the locality slice of the sustainability plan was what are we doing in place that is around prevention and proactive care. So hence why you'll see the other columns looking like zero when in fact they aren't. So all of this work is combined at a Greater Manchester level from each of the 10 localities, has been included within the sort of formal planning submissions that NHS GM has to do to the centre. The content in this slide deck is a moving feast, so it's already been updated at the as we've moved towards the back end of this week since these papers were produced and published. We are currently doing a quality analysis, quality assurance analysis of the detail within the big spreadsheet that sits behind this, just to understand where there might be some duplication, and we're continuing with the triangulation exercise of looking what's coming through from Greater Manchester, what's coming through from our provider intentions, and then the locality commissioning intentions and additional priorities, and we'll continue to do that piece until the very sort of end. The idea is that through that QA process and that triangulation, we will be able to create in very early April a more confirmed set of priorities for 25-26. And the intention is that we will strip back some of the more business as usual work and try to highlight and bring to the fore some of the things that we're going to have to work in partnership on over the next 12 months to make a real difference. So those will be the sort of cornerstone of our delivery plan for next year. In parallel, the Provider Collaborative Board will then hold a series of strategic priorities and what we refer to as ancillary priorities to make sure we've got the governance and assurance around that work and support. So where we need to escalate for resolving issues, we can do, and we can place that through the relevant governance, whether that be here or whether it be the locality board. Really importantly, and one of the things we said and committed to in our locality plan was understanding performance against our agreed plan. So we're currently having conversations around what do our performance arrangements looks like, and there's a strategic framework that's going to the locality board next week that describes how we might do that differently than we have done in the past 12 months. That has real relevance for a conversation here in the future at Health and Wellbeing Board, because some of those priorities that Helen brings back here from the deep dive priorities will be part and parcel of that annual delivery plan. And again, a plug, I seem to be doing lots of plugs this morning for things that are coming up, but we have a performance workshop on the 28th of March where we'll be looking through and agreeing, hopefully, that model by the end of that session. If anyone wants an invite, please just ask. So just some really high level next steps then. So we still need some sort of using old language commissioner to provide conversations around provider intentions and commissioning intentions and making sure that that completely aligns. And that is in the backdrop of cost improvement plans that we all respectively have in departments, functions and organisations that make up this partnership. So understanding that financial context is absolutely imperative to getting towards a final agreed plan for 25-26. So those are live conversations happening outside of this room. And by the end of by the end of March, we should be in a position to, as I said, nail down what that delivery plan looks like for next year. We'll continue the work on strengthening our performance arrangements so we know whether or not we've made a difference. And throughout this process, although it's not been an exact science, we've been trying to think about what those opportunities are for further investment. So when money does hopefully become available, even if it is drip fed and time limited, that we're able to act swiftly and invest money that does become available into the things that we know will have an impact and that align with our commitments around prevention, proactive care, reducing prevalence. So that concept of a sort of future priorities repository is something that we're working up through the Provider Collaborative Board so that we can, any emergent funds we can grasp. And I think that's it, Gareth, unless I've missed anything.
One more comment from me. I just want to link back to some of the funding and the finance conversation that you started in your introduction, with recent announcements, etc. So we know that GM and the NHS is facing a significant monster challenge financially for this year, next year, and for the foreseeable future. So it is so important. Firstly, on the performance, I just want to support that and plug that again. It's so important that we can demonstrate impact of anything we do, even the really small things, because otherwise it's going to be really hard to demonstrate the need for the funding. I think clearly, even though we're expecting some funding to come down in various funding streams, that is at risk clearly at the moment. So I think the intention for us and the ambition as a partnership needs to be so strong that we are brave and we do some of these things even if the funding doesn't come. And it's really easy to say that, and it's really hard to do, especially in my position of managing a delegated budget. But I think that ambition needs to be really strong throughout all this because it's going to be so difficult to spend any money in the future. And I know that's a really bleak but fairly obvious statement to make. So I think it's great that we've got this sort of joint process, and the process of being through the Tom's described has been really powerful, with all the partners taking part in this. But now it's about that leap and doing things a bit differently moving forward, within that context that all of our partners are facing. It's not just the ICB and NHS England, it's all of our partners are facing that. I just wanted to say that. Thank you.
Thanks, Gareth, and Tom for that report. Really interesting again, really good that we're setting out how we are going to move forward. Does anybody have any questions or comments? Heather?
Just a comment really, 10-year plan, and when that comes, what this I didn't hear that last word. Sorry.
Is it what?
I'm just saying that upskittled.
Upskittled, that was a word. I don't know that one. Okay. Yeah, I think I know what you mean.
Yeah. Well, rather than swear, that's the next best thing. But I mean, seriously, we don't know what's going to be coming down in the current climate, and the 10-year plan will receive high profile both nationally and locally, and it could well mean that we do have to be fleet of foot here and able to adjust the sustainability plan. And the other question really was for Tom was, have we had any feedback on the initial plan that we submitted?
Good question. So the feedback we've received is that all the plans have similarities across all of the 10 Greater Manchester authorities, but obviously there's a lean towards certain services in certain areas. So I think it was never going to be critiqued as such to say you're doing the wrong things. It was more of are there opportunities to collaborate at pan-GM level across a number of authorities. And that's the way they've done things. What they have produced, and again, apologies, it's not in here, but it's very high level. And the synopsis of the work that's happening in localities has been drafted and included within the final plan that NHS GM has to submit to the centre. Gareth's probably got the date in his head. I haven't, unfortunately, but in that final plan, there's a synopsis of what the localities are bringing to the table, for want of a better phrase. But no critique on what we submitted, just full support, really.
And I don't think in Trafford we're scared of collaboration, are we? As long as we don't get eclipsed at GM level, that's the only concern that I have with some of the collaboration. So thanks again, Tom, and thanks for the point. Do you want to come in on? Sorry.
Thank you. Just a quick comment. I think it's this is probably one of the best examples I've seen of bringing what is a very complex picture into something very simple that we can all understand. And those priorities are very clearly, I think, aligned to the 10-year plan as well. So there's a good future-proofing of what we expect to see there. I think also helpfully is then turning that, as you've described, Tom, into tangible delivery in April. And I think that's the key bit, really. It's understanding what each of us as partners are going to lead in that space. So look forward to being part of that.
Any further comments? Oh, Councillor Butt, sorry.
Thank you, Chair. Yes, just one of the points that you made about the locality ownership and monitoring of the outline plan. Are you envisage any kind of issues on that, or is it? Do you normally kind of have any kind of problems in the past, or I know things keep changing and organisational structure changes. So can you just sort of make a point on that, please?
Yes, I think if I've understood the question right, I think what we have in Trafford, and we have had for some time now, is actually a quite mature governance system and set of arrangements with really great engagement from all partners in all different levels of that system governance. And we will, and it plays to Adam's point actually, once we have that credible and agreed plan for 25-26, there has to be that sits alongside that clear roles and responsibilities for who's going to do what by when, and then the governance that wraps around that so that we can hold ourselves individually and collectively to account. So that will be here in some instances, it will be in the locality board and it will be in the provider collaborative board. And although the slides aren't with you today, the performance framework that we've drafted up for conversation at the performance workshop and at the locality board next week tries to articulate where that responsibility sits and where the reports will go into. So hope, in answer to your question, I don't envisage there being any issues with that. The hard work is getting to that agreed plan, because once we've got that, I think the responsibilities and who does what should be relatively straightforward. It's just making sure we've got the capacity and commitment to follow through on that, and playing to Heather's point, being flexible in year as things emerge from the national announcements where we might have to pivot and deprioritise, and having an agreed methodology of how we do that is really important, I think.
Thanks, Tom. Okay, no further questions, so we'll just note that report, and I forgot to say we've noted the previous report as well, George, so if we can just get that on the minutes, thank you so much. And if we can now move on to item 6, which is the Better Care Fund, the Q3 return, and that's going to be you to lead. And Tom, are you going to come in with some support? No?
No, I don't think so.
Just
going to. I'll try and do it on my own.
You know, because I know that sometimes we never allow you to speak. Go for it.
Yeah. So I'll be relatively brief on this. It's the quarter return that you've seen each quarter for the last few years, really. So the key important part to look at, and I do recognise it's not a brilliant template to work through and to understand all of it. So on page 7 of that document is a short summary of the four agreed metrics that we agreed to include in the Better Care Fund. So the 4 are: the first one, unplanned hospital admissions for chronic conditions. So you'll see from the summary there that we are on track to deliver that target. One of the key things for this year was the establishment of the crisis response service, which I think came online last year, and that's clearly having a big impact in this area. And there's a gap, wasn't it, when we talked about this previously. So that's really helpful. And hopefully, as we move forward, if we develop a hospital at home service for Trafford as well, that will really have an impact on those avoidable admissions, stepping people up to another service rather than hospital. So that's a positive picture so far. For the second one, it's discharge, normal place of residence. I mean, incredibly important to patients and their families. Again, we're on track to deliver that and actually, to exceed that target. So that's positive as well. And there's a description in the achievements column of some of the things we've done to support that in partnership again with LCO colleagues. So that is positive. Number 3 is in terms of falls, and you see the numbers are quite impressive there in terms of the reduction against plan for the numbers of people who admitted over 65 due to a fall. So again, that is due to the work we've done collectively around that. So that has moved absolutely in the right direction. And then the 4th one, in terms of the rate of permanent admissions to care homes, that's not measured each quarter. That's only done once a year, but we are on course to deliver that reduction. I think despite an increase in the cohorts, the numbers of 65s have grown year on year, as you expect in Trafford, but we are expecting to deliver against that metric as well. So to summarise, it's relatively good performance against those 4. When they are only 4 metrics in the Better Care Fund, and there's a whole different conversation around performance against some of the other performance metrics and the constitutional standards. But for the BCF, that's a positive picture. So our attention now has moved to the BCF plan for 25-26, and there's lots of conversations taking place between ICB colleagues and council colleagues. And to date, all we've had to do is submit a fairly high-level narrative. So we're not sharing that at this stage. It's still a work in progress, but we will bring back our BCF plan probably to the next meeting, Tom. I think it'll be ready, won't it, for the May meeting? So we'll be bringing that back in May. And it'll be very similar themes, but hopefully, some more things built in as well. Thank you, Chair.
Thanks, Gareth. think that, you know, the stuff that we're talking about around hospital at home, excuse me, those are priorities for the Integrated Care Partnership Board as well at GM, you know, care at home, those are the things that we need to be doing so that we can support people not to have to present at that front door at A&E and stuff. So, yeah, we've got a good, it's got a really good pen with it wrote on, so he'll never forget. So, yeah, I think that, you know, the way that we're doing things, it feels really, really positive. So, any questions or comments from anybody? Heather? Totally agree. And it isn't the first time that you've mentioned district nursing to us.
I'm mentioning it everywhere.
Yeah, and we appreciate that, Heather, because, you know, we need to be constantly reminded if we're forgetting about those kind of things, because if we don't have the district nurse staffing numbers, we aren't going to be able to deliver care in hospital at home. So I totally agree. Gareth, I think you want to come back in.
Yeah, so totally agree, and don't apologise for raising that. I mean, I do the same. Every meeting I go into GM, I talk about Trafford's district nursing service as well, so that's really positive. I think just to say that it is a key focus now, as you know, it's the #1 priority for the GM Community Services Programme, so district nursing is front and centre. So that should be a good thing for Trafford. I'm not suggesting that, you know, there's going to be lots of new money, but that should be a good thing, and there's a real focus on it at GM level, and we clearly are an outlier in that way. So don't apologise for raising it. Please keep doing it. Yeah.
Thank you. Nothing further. Thank you. So if we can note the report, and thanks again, Griff. If we, excuse me, if we move on to item 7, I don't know what's gone off. My throat's gone all croaky. I've got some drink there. So, Fairer Health for Trafford update. So that's going to be you.
Yeah, no.
Okay. So thank you, Helen.
Hi, I just wanted to give you an update on the work, the Fairer Health for Trafford update, which is our strategic inequalities approach. But we're doing it in a very tactical way. So that's a lot of kind of jargonistic words, isn't it? But what we're actually doing is understanding what the inequalities are and then putting recommendations in place to address the inequalities. So I'm sure Zoe came to the last board just to remind you that our priority groups are people with a learning disability, people who are unpaid carers, and people with a serious mental illness. And we know that the evidence behind the outcomes for these groups of people are really poor in Trafford, so a real focus on that. Loads of activity, loads of work going on in this area. It's really exciting, and Zoe has been brilliant in leading this programme of work for us. So where we are with learning disabilities is we have a clinical psychologist with us, Amy, who is out and about. She's talking to providers, she's talking to families, she's doing the evidence, she's understanding exactly what the issues are. Obviously, when we look at published evidence, sometimes it's quite strategic level stuff, but this is actually in Trafford what is affecting people's ability to access service and support. So Amy unfortunately leaves us because she's on placement at the end of March, but has been doing a fabulous piece of work, and will share with us a set of recommendations into the partnership once known. The unpaid carers work, we have a GP registrar with us at the moment called Olfet, and she has an interest in unpaid carers. She's been digging around in the data for us at GP level as a starting point, really, to understand how our primary care colleagues can support our carers, unpaid carers. Because if we think about the role of unpaid carers, we know that the inequalities are significant, particularly for women. So there's like a double inequality there, isn't there, around being an unpaid carer, but also the impact on women's health. Olfat's looked at the data initially, and some of the initial findings are quite stark. So what we've seen is 80% of the consultations with primary care, so Jane, you might find this interesting, 80% of the contacts with primary care for an unpaid carer are registered as needing social economic support. So it's that kind of health. It's thinking about what can we put in place to support our carers so that they don't have to go through primary care as their source of support. And, you know, it's about reducing demand, but also supporting our carers earlier. The piece of work, so that work's ongoing. We have a programme of work going on around people with serious mental illness. So again, we've got Kiva, who is a clinical psychologist on placement with us, and we've already done that piece of work looking at how primary care can support people with serious mental illness. So we've got that chunk of evidence, and then Kiva is going out and about talking to other services, and we've identified that there is a service called Manchester Mind that supports people with serious mental illness in our practices, which was something we weren't aware of, and we're just working with them to understand where they are, which practices they're currently working out of, and whether they are in the right locations to be doing that. So some of this, again, is just changing things very slightly to make a difference. So there are 3 priorities, lots of really exciting work going on there. Some of the themes that are coming out won't surprise anyone sat around the board. Access to information, coding and recording are 2 of the big themes coming out of some of this work. So, you know, that lack of understanding of who is in this group and where they are, you know, some of that is really key, initial crucial findings. Going forward, Zoe is looking at metrics as well to understand how we actually measure our impact, both going back to what Gareth has said, the immediate kind of action. So if we do make a change, how can we capture that that change has had an impact, but also those long-term metrics as well, because we recognise that health inequalities isn't something that can be addressed within 6-12 months. But in terms of the programme of work for Fairer Health, it's developing significantly, and it is about now thinking about how we kind of shape that within our system further, and whether it is about working with our different boards around stretch targets. So if there is a priority, can we have a stretch target into some of those priorities for people who are affected by health inequality? So that's some of the discussion we're thinking about at the moment. And we will bring a fuller report around the work of Fairer Health, probably to the May-June board, because that will be 12 months since we had our initial prioritisation exercise. But really positive, really good. And it's going through to the locality board as well, to the June board. So it's about getting that strategic oversight and ownership of it as well. Thank you.
Thank you, Helen, for the update. Does anybody have any questions or comments for Helen? Councillor Brophy?
Just a brief question. You outlined the 3 priorities. 2 of them were carers and 1 was people with serious mental illness. In terms of the overlap between those, so those people with serious mental illness will have carers. So of the priorities, how are you finding they all link together?
I think this is one of our challenges in public health, that nothing has clear boundaries, does it? So we are looking and thinking about how they all link together, and Zoe's doing a great job of kind of mind mapping all of that as well. So they will have impacts, you know, they can't be dealt with in isolation. Activity that we do within serious mental illness and the learning disability cohorts will have a hopefully positive impact on carers' health as well, or thinking about those opportunities that if we develop in an intervention or initiative for LD or serious mental illness, then is there an opportunity there for carers to have a, you know, the respite and the care that they need as well. So very much thinking about it in a system way. We say a system way, but it's actually how people live their lives, isn't it? And understanding and what this looks like for them.
Anything further? No? Thank you again, Helen, for that update. So if we can move on to item 8, which is reducing the impact of long-term conditions in Trafford. You're going to start this off, Helen, and we have some other colleagues who've joined us. So when you speak, if you're able just to tell us where you're from, so that'd be really helpful for the board. And also we don't have any facilities for sharing slides, so people are just having to view slides on their laptop. So thank you.
Thanks. So I just wanted to introduce long-term conditions and kind of put the context in as to why we're talking about long-term conditions at the Health and Wellbeing Board. And this is about how we work together in public health and the ICB in terms of addressing the different levels around prevention and inequality. And Liz, our public health registrar, is going to talk us through the links between the priorities we have as a Health and Wellbeing Board and long-term conditions, and then how we work as a system. Will flow around the table seamlessly with a fabulous example from Adrian, and then a closing piece around our health checks as well, which is a brilliant programme of work for Trafford. So I'll hand over to Liz. Thanks, Liz.
Is this picking me up? Yeah, okay, so I'm Liz Biscoe, I'm a public health registrar, as Helen's just said. I was asked to just kind of produce a few slides to kind of give us a reminder of why we have the priorities that we have as a health and wellbeing board. In particular, priorities around tobacco, physical activity, food-related ill health and healthy weight, alcohol and mental health and wellbeing. And the main reason those have become the priorities are because they are the main modifiable risk factors for long-term conditions, sometimes known as non-communicable diseases, depending on sort of which sources you're looking at. And the four that were kind of originally kind of considered as the big four by the World Health Organization and other organizations: cancer, cardiovascular disease, diabetes, and long-term respiratory conditions, including COPD. On the slide that I've created, I've also put in mental ill health in there because, as Helen said, there's already work going on around that, but also there's quite a complex interaction between mental health and long-term conditions, mental well-being, and I'll get into that in a minute. But the main reason we look at long-term conditions is because they have a really big impact on our healthy life expectancy, which is the proportion of people's lives that they live in good health, able to get on with their day-to-day activities without any problems. And over the last few years, the graph on the right-hand side of the slide, I think it's on page 32, is showing that in England, the healthy life expectancy has been going down. Some of that is COVID related, but also that kind of stalling of previous improvement was happening pre-COVID. We've picked up in Trafford a little bit in the last couple of years. We've actually gone up a little bit on that graph, but it would take quite a large jump to get back to where you would have predicted we would be based on our previous trajectory prior to COVID happening. So as Helen said, we're going to talk about these the priorities and conditions, and my colleagues will fill you in on what we're doing about it. The slide on page 34 outlines that, if you kind of read it from right-hand side backwards, it's the one with the arrows on and the boxes, if anyone's struggling to find it. So essentially, this slide is to outline that globally, long-term conditions. Sorry, are you struggling? That slide, yes, that's the correct one. Yeah. So if you look at the red arrow box, these long-term conditions actually cause around 80% of deaths worldwide. It's much higher, quite a significant issue in, sorry, excuse me, lost my train of thought. But yeah, so it's a big problem. It causes problems in quality of life, inequality of experience. When you look at what is sort of contributing to that outcome, around 20% of it is like the actual sort of ill health and the care that one receives when you've got a long-term condition. And then around 30% is to do with like the modifiable risk factors, but actually a really large percentage of the causes of the causes, and where we can put in actions to prevent these outcomes is with the socio-economic conditions or the wider determinants of health. The next few slides, I have gone into quite a lot of detail about those particular diseases. I don't intend to read them all because we've not got time, and you've got the papers, but I think there were just a few kind of quite startling statistics and things that came out when I was looking through the data that we've got. In particular, under 75 mortality rate, so that's the number of people per 100,000 people who die under the age of 75 from cardiovascular disease in Trafford. It is following the same pattern as the annual trends, but from around 2014, the trend that had been coming down, so reducing that mortality rate, has kind of stalled, and there's lots of reasons why that will be, but it's another kind of indicator that whatever has been happening isn't working as well as it was previously. And in Trafford, it's also notable, and this is a statistic for Trafford, but it's also, if you look at the GM levels, the whole of GM kind of comes up way above the England rate for admissions for stroke to hospital, even though our actual rate of stroke isn't massively high. The fact that people are, I'm sorry, I haven't got the time to go into all the details on the stats, but if there's any questions, I'm happy to try and field them, or if not, I'll find my colleagues who can. The slide on diabetes, I think the key thing I wanted to point out was that across Greater Manchester, because that's the level I've got the data for, that people with diabetes are most likely to live in the lowest 2 deprivation quintiles. So in the poorer half of our society, that rate of diabetes, like sort of 45% of diabetics live in poverty effectively. There's some stats on cancer. I think the point I wanted to make around cancer is that these days people are living a lot longer after cancer. So whilst we've got obviously a responsibility for reducing cancer in the first place, the contribution it makes to poor healthy life or unhealthy life is getting longer. People are living around 10 years from diagnosis on average. That's very, very much longer for some cancers and very much shorter for others. But that has increased quite considerably in the last 20 years or so. So it's going to be creating quite a burden on our health systems going forward. And rates are still going up across the board, and particularly in younger people. People under 50, the rate of cancers diagnosed has gone up 24% since 1995, just in that cohort. It's still very rare in younger people, but it's something to be aware of for future planning for health services. Respiratory disease, again, the main kind of take home from that slide is that mortality rates from COPD are really strongly correlated with deprivation, but so is prevalence of smoking, and a lot of our wider determinants kind of feed into that. So I'll move on because we haven't got a lot of time. So I wanted to just very briefly touch on the role of mental health. On the slide on page 39, or actually it might be 41 if you're looking at it in an Adobe reader thing. Was it 67 on? Oh, sorry, I've got a different version of the notes on mine. Sorry. Mental ill health is kind of a long-term condition, and it's kind of, as Helen's probably gone into a little bit, I've missed some of what she has reported already, but mortality and morbidity from those long-term conditions in people with severe mental illness is much higher than the general population. Mortality from CVD, cardiovascular disease, chronic respiratory disease and cancer is 4 times that of anybody who hasn't got a severe mental illness. So there's a lot of there is data around sort of things like smoking rates in people with SMI are much higher. There's an association between alcohol use and mental illness. Yeah, those risk factors are kind of part of that package as well. As I mentioned earlier, one of the board's priorities is around mental well-being, and severe mental illness is a slightly different kettle of fish, but if we are improving mental health and well-being, the hope would be it would have benefits for outcomes for other long-term conditions, because there's a kind of spectrum on these things. It's, there are those specifically maybe more organic mental illnesses that are unrelated to necessarily being caused directly by those risk factors, but there's a lot of mental unwellness that is on that spectrum that's related with those risk factors, but also can play into cardiovascular disease, stress, causes high blood pressure, etc. So what does it mean? What's the point of going through all of this reminder? And as I said, there's sort of different levels at which we can act to try and prevent that outcome of significant mortality and morbidity. And it's about the different parts of the partnership and different parts of our system working at different levels. So on the graph that's got three kind of triangles, the wedges, this is to kind of indicate that we've got some impact absolutely will be made by our acute colleagues treating the those long-term conditions directly. That's almost D on this graph. But then you've got sort of treating high blood pressure, making sure diabetes is well controlled. Those sort of, it's kind of secondary prevention. So you've already got a disease, you've already got the beginnings of a process happening, and it's trying to prevent that turning into something that's much worse. And that can give some, obviously will give some benefit, but in the short term. But if we are looking at trying to make the biggest improvements in having the biggest impacts, we also need to look at reducing those risk factors directly through programs of smoking cessation, etc., but also looking at those wider determinants of health. And over the longer term, although it does take a while to get there, those do create the biggest benefits in preventing those outcomes. So everybody's got a role. We all need to be doing what we're doing. And I'll pass over to Helen. Or, oh, sorry, Adrian.
Hi, morning everybody. I'm Cathy O'Driscoll. I'm the Associate Director of Delivery and Transformation here in Trafford locality. So we're just going to move on to the primary care aspects as outlined in the paper. So what we wanted to do, as Helen said, is also emphasise about how much partnership working we were able to demonstrate. So there's a real seamless support and network between both our public health teams, and obviously then develop an integration into the neighbours, and that'll become a little bit clearer when we go through some more of our priorities and what's been delivered in this year. Just wanted to focus for the first couple of slides on the GM primary care quality contract for 24-25. So for the first time we had additional investment into primary care to really specifically look at the two areas of CVD and diabetes. So this was to attribute an additional payment into primary care over and above what can be received through the quality and outcomes, the QOF payments that primary care receive. So for each practice, what we did was we identified known CVD and diabetes patients that were at the highest risk, and therefore enabled practices to have the capacity and capability through additional investment to really work on those patients and prioritise them to get an increase prioritisation of their care and also of the recall systems in general practice. For the high-risk cohort of patients, practices were asked to perform streamlined high-risk reviews on this group specifically, and there were 6 criteria areas which are highlighted in the presentation. And I think what was demonstrated for the first year of this quality scheme was that actually giving primary care some additional investment so that they could invest in the appropriate resources in primary care, we were able to see some really tangible and extremely beneficial for patients results in those 2 areas specifically. And on the second slide for our slides, I think it's on page 44, it might be slightly different in your packs. It shows what the performance was across those quality contracts for 24-25 for those areas. So when we first started in March 24, it was 33% of high-risk patients had a recorded outcome in the 6 clinical areas. And then as of March 25, that had increased to 47. And even though that threshold doesn't seem like a massive jump, it's a significant amount of patients that have now received the appropriate care and support. I'm sure you'll also be pleased to know that we are continuing with that quality contract for 25-26, and we're very much hoping that that additional investment will be sustained and maintained and obviously grow and increase as the year goes on. And we are focusing on some slightly different areas as well, and I'm sure we'll be able to bring back those in more detail. Thanks, Alex.
Hello everyone, I'm Alex Cotton, Head of Transformation Delivery, working with Cathy. So the bit that I'm going to go on to now is some of the grant investments that we received initially in 2023-24, but with delivery across that year and into 24-25. I'll just touch on a few because then hand over to Adrian to talk about some of the detail. But really, we were awarded some grants, so non-recurrent monies, to really drive forward bringing back the routine diabetes prevention, identification, the management and care, to actually focus back on that very preventative measure and also reducing the impact of diabetes and other long-term conditions, with a focus of delivering against the NHS long-term plan. Really fortunate in that year that the total funding was 292,000, which, you know, in the current climate is a real significant amount of investment into Trafford locality. And the main schemes that were delivered through that was around the Parting Practice Family Care Focused Care Practitioner, which does not roll off the tongue, which helps with case finding. We developed development of leisure partners to really have that focus around physical activities and interventions through GP referral about long-term conditions specifically, so growing on the work that they're already doing. There was also investment around the National Diabetes Prevention Programme and how we increase the uptake in that area. So that's a national programme available to patients, but not just in Trafford, but across GM. There isn't always a great uptake. So we really wanted to invest in additional engagement support, really, through Reid, who provides National Diabetes Prevention Programme, really to work with partners and GP practices to kind of identify patients and refer into that programme. And most importantly, in many ways, there's a big programmes around Partington and North Trafford, which was really community and partner focused about how we prevent long-term conditions within those communities. I won't touch too long on those because I don't want to take away from all the good work. So some of the bits I'll say about the service providers, so I've always mentioned the Trafford Leisure and Be Active, and again, that's around how we enhanced our offer with a focus on long-term conditions. I should note the work we did with Arriva. So we used part of grant monies to support our patients struggling with weight management, and there were changes to our Tier 3 service. So it was additional capacity to support our patients through that behavioural change and lifestyle change. As I say, Reid, we employed an engagement officer to increase uptake, and actually that's really much, we now want to move into how that works with the neighbourhoods, so not just for general practice, but really build on the relationships that were done with PCNs over the last 12 months. And as I say, the Partington programme and the North Trafford programme. On the following slide, there's just some figures, and I think the main one here is to note the impact of that engagement officer from Reid. As you can see, we were quite low on our uptake of the National Diabetes Programme for a considerable amount of time, and then we've shot up. We've seen really significant improvement in the last quarter of last year, and I think that just shows how much having a dedicated person who can work within with both our practices, but also in our wider footprint, it really does have an impact. And then I'm going to hand over to you, Adrian, if that's all right with you, and he's going to share the details of some of the great work within Partington.
So my name's Adrian Smith. I'm neighbourhood lead with TLCO, and I think it's my job today to bring to life some of the VCFSE sector work. So I'm going to talk a little bit about the work in Partington and a little bit less about the work in North, just because I happen to have a closer relationship with Partington. So for the VCFSE part of the work, the grant awards enabled a coalition of voluntary sector organisations to come together with some of our statutory partners, with Trafford Leisure, with Be Active Ulmston, and with primary care colleagues. In Partington, the brand Feel Better Partington, so you can see that, it's on my page 75, and they brought together a brand, and in North that was Healthier, Happier Me. And I think kind of that brand, I'll mention that that's kind of relevant because that helped with, I suppose, the connectivity and resonance across some the local communities. And as we go into the next stage of work, then the brand, although the programme is changing, that brand exists to resonate kind of with those communities as well. So I provided a little bit of support to Feel Better Partington, and what that means is I help facilitate the provider meetings. Similar support was provided through Trafford Community Collective in North Trafford. And the diagram you can see on, it's my page 25, I suppose summarises the approach. So across both projects, we had a hub and spoke approach. So one organisation acted as the hub. So they kind of managed referrals. They supported the case finding element of the programme. And then what they supported was a joined up, flexible offer into that wider set of community providers, the other VCFSE organisations. And that looked quite different in each place. So in Partington, for example, we tended to have a split across some thematic audiences, in the sense that Blue Sky provided a particular focus on those people who had higher emotional and mental health concerns. We had a Hidden Treasure Trust there. We also in Partington had Age UK, who provided support around benefit maximisation. In North, what we were able to do was work with the local providers there, the VCFSE organisations, who could bring in their specialisms, their relationships across the community networks. So for example, you had African Caribbean Care Group working with African Caribbean communities. You had LMCP, who focused in particular on South Asian communities, men, and kind of so on. So the range of interventions, that flexible support offer that I'm talking about, they can have ranged from things like cooking classes, which were kind of common across different organisations, DASH diabetes cooking workshops, LMCP ran face-to-face workshops, we had peer support groups, we did cooking demos, we did physical activity classes. So that flexible support offer, if you think, was able to kind of give people who were referred into programme support that matched what their kind of expressed or identified needs were. The other bit of the programme that worked, I have to say, exceptionally well was relationships with primary care. So in Partington, for example, because of that funding that was made to the focus care practitioner, there was an absolute direct route and literally picking up telephones to talk about kind of referrals, two-way support in terms of walking people back into primary care or other services. So I think later on, I'm just going to kind of touch upon that as one of my observations about kind of what success looks like. So evaluation will be carried out by Healthwatch Trafford. So they are going to support us across both programmes. We have obviously coded referrals because they kind of came in across primary care. So that will allow some reporting to take place to understand some of the differences across the cohorts. And as part of that evaluation as well, we're going to carry out some qualitative interviews with residents, so with residents and patients who took part, but also with system leaders, if you like. So we're keen to understand what the system learning is from this process as well. And I think, Liz, reflecting back on your slide about the socio-economic kind of factors determining it, I think in terms of our scope of evaluation, that's going to be really, really important. I'll briefly mention kind of with ICB colleagues. So I joined this kind of process when I came into post a tiny bit later, but one of my observations, and I'm keen to explore this as part of the evaluation, was the collaborative commissioning process, and it very much was a collaborative process. So the Brooks and I, as the staff members from Alex's and Kathy's team who kind of led this process, kind of literally came and sat down with local providers. And the starting point was, you know, this is kind of some of our evidence about kind of need in the area. Talk to us about your insight and let's talk about what solutions might look like. And that process took longer. It definitely took longer, but I think the service model that we were left with, that we developed, was very much kind of better for it. We were affected by, I mean, this is so timely, we were affected by the previous disruption at the ICB that significantly impacted, I think. And there was, it felt like there was a little bit of a gap. So that meant things like the data governance requirements kind of just landed on the programme at what felt like a late stage. And they took about 3 months of people's time out of delivery. So I think that's kind of an observation just in terms of process of that kind of commissioning process. But I kind of touched upon how impressive the relationships across primary care have been. And they kind of definitely have, and the practices are very keen, particularly in Partington, really keen for those relationships to continue and develop. I think another observation is that that process has allowed collaboration and coordination between the different VCFSE providers. So they come together regularly. Rather than thinking about their piece of the pie, they're thinking about that pie collectively and what that kind of might look like, about how joining up works, about the referral process into each other's kind of services. The majority of clients or patients did come through that case finding process. It was really, really effective. But that's not to underestimate the, I suppose, the ability of all those VCFSE organisations to reach out into their communities in very specific and kind of very targeted ways. So we have lots of examples in terms of case studies already about people being walked from place to place to place. And I think that's kind of a really important about this kind of detailed and community-focused intervention. I think in terms of next year, so I suppose I'll kind of skip on to kind of the little bit about next year. It's a significantly smaller resource that we are kind of left with. So thinking about the continuation of both Feel Better Partington or Healthier, Happier Me, it's going to look different, but kind of nonetheless, that additional resource will allow that collaboration and coordination to continue. It allows us to focus in on kind of three things. So those three things are blood pressure checks. So in North in particular, because that was one of your focuses around hypertension, that will allow us to some really targeted activity and some brief advice conversations. We've kept a little bit of resource to maintain that case finding element, albeit smaller. So that's just to enable those two hub BCFAC organisations to continue the conversations, relationships with the PCN or with the practices in Partington. And then a little bit of that resource as well to continue some of that engagement activity that's proved so important to hook people, to engage people, to bring them into that kind of wider support offer. And then the bit, I mean, I'm excited about, genuinely excited about all of that. But the bit that kind of tickles me a little bit more is the work around, the planned work around the digital champions. So that's the work with Blue Sky. And my feeling, my hunch is that we will move into quite an innovative space with that work. So that's kind of thinking about how we engage people around digital support offers. It's very strongly linked to digital inclusion work. It's working collaboratively with our colleagues in the local authority. I think it's picking up from some of the National Health Institute research around digital hubs. So we'll be exploring things as diverse as, you know, use of and sign up to the NHS app, through to how some of our telecare or how some of our digital offers can support people around things like meds management or monitoring. And the advantage of working with Blue Sky is obviously that we can spread into all of our neighbourhood localities as well. And I suppose just as neighbourhood lead, it would probably be a little bit remiss of me just to kind of, I suppose, point out that for me, this work absolutely fits into our neighbourhood approach, you know, in terms of the coordination, the collaboration, our focus on population health and prevention. And it's been really exciting to be able to bring back the updates to our neighbourhood networks, and it will be to share that learning with colleagues as well. Thank you.
Thanks, is it over to me? So I'm Jo Bryan, Programme Manager at Trafford Public Health. I'm also going to tell you about our programme of NHS health checks, but possibly unlike the other presenters, I actually really need your help. I've got an issue, a problem, and I really need your advice on how we go forward with it. So NHS health checks, as you probably know, are for 40 to 74-year-olds, and it's all about preventing this CVD risk, which colleagues have been discussing. They have been proven to be really effective. They've got good return on investment. There's evidence that they significantly lower the person's likelihood of hospital admission and of death in the 5 years after the check. So they're a really positive thing. We have done some work recently to look at this STARS framework, which is kind of like our governance of the programme, how it's working and how we perform. This is a national kind of baseline. We do really well in stuff like delivery, commissioning, data, health improvement. We don't do so well in governance, partnership working, communications and marketing, and innovation, because we don't use any digital tools. Liz has already told you about the kind of CVD background, so I won't go through that. Obviously, as you would expect, we've got a lot of disparities in CVD across Trafford. We've got places like Urmston with high hypertension rates. We've obviously got the north with high diabetes. We've got high stroke rates in Urmston and Partington. You know, we know those inequalities, and some of those might be a bit skewed by kind of numbers of care homes or the local population. So basically, our NHS health check service is provided by GPs and nurses in primary care. We perform really well in Trafford. We do very good numbers of health checks compared to the England average. We perform pretty well across the borough. We're doing some more in the west. We're doing some more in the north, but it will be more difficult to get those populations to engage as a whole. So you can kind of understand that. But overall, great performance. We have slightly more women attending health checks, but it's not massively concerning. We have a really good proportion of people from ethnically diverse communities coming to their health check, which is, great news. We also invite and deliver well to areas of deprivation, which I wasn't expecting when we looked at the data. Fantastic. We do invite more younger people. This is obviously a preventative programme, so we really want to be inviting the people at the younger age range. More of the NHS health checks are taken up by the older age range, so that's maybe an area of concern for us. And we also have some issues in delivery in terms of like the list of everything you're supposed to do in a health check isn't always followed through 100% by practices. And unfortunately, that's worse in some of our more deprived areas. So that's an area that we need to look at. We have good outcomes, nearly 4.5 onward referrals a year as a result of health checks, lots of diagnoses of things like hypertension, kidney disease, diabetes, which is great. We've had some additional bits of innovation in Trafford over recent years. So we've obviously had the Health in Communities project in Sale and Central PCN, which has done 114 health checks and focused on people who were less engaged with their practice and in areas of higher deprivation. We've got some projects working with the VCSE organisations where they're doing health checks to specific people like older people, people with learning disabilities, ethnically diverse who may be less likely to take up their health check. We did a pilot project with South Asian and ethnically diverse populations in the north of the borough to try and see if we could go under 40, because obviously prevention needs to be shifted lower for those populations. So we worked from 25 to 39 and they had 148 people engaged. And then you may have heard recently we've done some workplace health checks across Trafford, both here at the council and in some employers in Trafford Park, to try and target people who maybe are shift workers and might be less likely to take up the health check because of their working patterns. So as you can see, we've got plenty of strengths in the health check programme. We do need to look at governance. We do need to look at some of these incomplete health checks. There's a few things there that we can build on and do better with. We've got lots of opportunities. We could build on stuff like the Health in Communities. We've got voluntary sector organisations doing health checks. We could get them as NHS health checks and then feed them into primary care. Absolutely, all of that would be really welcomed. My problem is that we're performing too well for the budget. So I put in the slides that over the past 2 years, the budget has gone over by 120k. We recalculated it yesterday. It's actually gone over by 140k. So this is a great program. It's really working well. We're actually targeting the right people, but we can't afford it. So that's our real challenge in public health, and that's what I need your help with. So it's about, maybe we just need to continue to make it as good value for money as it is. So maybe we just need to target even more populations that we really want, so that then the fact that we're overspent is, well, at least we're overspent on targeting the right people. So maybe we do that. Maybe we've probably got a bit more we could do on impact and outcomes. It'd be great to build on these opportunities with the VCSE and Health in Communities, but how can we do that without the additional resource that's there? And how can we as a system, how can you help me in those kind of governance issues? We're sort of doing this with primary care just on our own. I mean, I don't think we can, I know we perform badly in marketing and comms. I don't know if I particularly want to promote health checks out to the general population when we're doing so well with targeted work. But so I'm wondering about governance. I don't know if there's anything that already exists in the system that we could like piggyback on that could look after health checks from that point of view. But really, my main issue is the targeting and the money and how we're almost having to ignore opportunities because we can't afford what we've already got.
Thank you all for that. I mean, that was a fantastic presentation and really choreographed between you. Have you had a practice? Have you done that? No. Have you had a run through? I thought that was really good. So what I'm going to suggest is we have 5-10 minutes just on that specific point, Joe, and then we'll have a discussion. I'm sure there are some thoughts, and then we can have another 10 minutes on questions. I mean, I've got about 10 questions, and I won't use them all, but that prompted so many thoughts. It always does when we talk about this kind of thing, doesn't it? So perhaps we'll go around the table a bit later and come back to that. So just to be really clear on the health checks and what you want us to do is just to have a discussion now about what we can do, how we can move forward with this, albeit within that funding constraint, and then perhaps a little bit on the governance. Is that okay?
Yeah.
So can I open that up just on the first bit then? First, yeah, Councillor Butt.
Yeah, 2 points I wanted to make was one is you talk about certain groups, like say Asian groups, your highest propensity for diabetes, but you're only focused on the northern side, you know, in Partington, this area. Whereas there's other areas which have got those people with the higher needs. Are you not able to? I realise, you know, the budget constraints. So that point, I mean, it's concerning. You know, you've got this 7% people undiagnosed. So and that's obviously having that impact. And I've got another point, but I'll just ask if you could just.
So just on that, so yes, we had a specific project that operated in the north, and we chose the north because that had the highest percentage of people from South Asian populations there. So that was obviously the most sensible place to have that biggest impact. But don't forget my slide on generally primary care are targeting fairly well to ethnically diverse populations as a whole. So across the entire borough, we're not performing too badly on that. I think, again, going back to like my first point of how we can continue to target this programme, I think if we could somehow make it easy for primary care to target even more through perhaps designing searches that they can use on their systems so that they're inviting more and more of the right people. Totally agree with you. That would be amazing, and we should do that.
Okay, and if I can just make the second point, is on the testing, you know, diagnostics. Is there any method of? I mean, we really need to encourage innovation within the testing, so that it makes it easier and quicker. And capture that kind of information. I mean, I know you talk about going into the groups, you know, and you've got the organisation like Blue Sky you're perhaps talking to, but where I mean, if the innovation came and it was much quicker, then you could have open access to a lot more people who might, you know, literally off the street that can come in to have some tests done. And pick up on those unknowns.
Absolutely, and so there are devices that can be used out in the community to test things like blood glucose, cholesterol, and through some of the programs like Health in Communities, they were used out in local community centres in exactly the way that you describe. They do cost to buy, they do cost to use, and it would be great if we could have a lot more of our voluntary sector partners having access and being trained in how to use those types of devices.
This is what I was just going to say, you know, that with the innovation, rather than having specialists, medical people having do those, if ordinary folk could do that, you know, it would probably catch more people.
Absolutely.
Get more organisations involved.
You don't have to be medically qualified to undertake, you know, to use some of that equipment. It's just more about how do we use the money that we've got Do we continue to use it in the way that we're using it, which is working pretty well, but it's not maybe as innovative as some of the things that you're talking about? Or do we stop doing some of that so that we can use some of that money to do some more of those innovations? And would that target more of the right people or not? And I guess that's a bigger decision than for just me to make. That's a collaborative one here today.
Thank you. Jane?
Thank you, that was a great presentation. I felt like I was at the theatre with the way you kind of coordinated all the bits amongst the team. So thank you for that. Very inspiring work as well. Felt very encouraged by what you're saying. I'm going to stick to the question that you asked. We want the final bit first, and then I've got some other points on the other bits of presentation. But as an idea, this is what you want, ideas. So I spent my working life, apart from being a counsellor, working in public health, and in the acute sector in Wythenshawe Hospital, actually working with people with complex diabetes, and usually they're the people with either type 1 or type 2 that have, you know, are not well managed in the community, because that's only the time you come into hospital. So one of the things that I noticed from working in those two sectors is that the health sector, the acute sector, works very different to primary care in terms of their approach to things. And I think one of the areas of communication that perhaps doesn't work as well as it could is the staff within the acute sector. There's a massive population. How many people, for example, in Trafford work at Wythenshawe Hospital or at MFT in some capacity? It's a huge employer of people. Those people that work there probably are, I'd say, equal in all of those health outcomes as the rest of the population. Health workers themselves are not that healthy. So having worked at Wythenshawe Hospital for sort of 3 or 4 years, I feel the health and wellbeing programs there don't actually address the health of the staff in the way, on all of those sectors, on the diabetes, on the cardiovascular disease, on the healthy eating, on the smoking, on the mental well-being. All of those things aren't addressed within the staff population. And if you were able to address it there's 2 factors. I think those health workers can become the drivers of health checks, and this is the benefits of having them, because often they don't. If they're very fatalistic about, oh, you've got diabetes or you've got obesity, there's not a lot that goes on to reverse that. I'm wondering if more work with those health workers themselves might yield some positive benefits, both for them themselves, but also on the way they advocate for the health checks.
Just in answer to that, the workplace health checks program that we did recently, we really did find that the employees that had them done said that they just would not have gone to their GP. They just haven't got time. So I would expect that hospital staff would be in exactly the same situation. Now, we do have links in our team through public health colleagues at MFT, so it may be worth us following up that conversation to just kind of understand what their offer is and whether there is anything more that they can do. Again, it's difficult because unless MFT themselves, through our colleague, would be happy to use our learning from the workplace health checks pilot to implement that within MFT, that would be amazing. If not, it comes back to that same thing. There's only there's a finite pot which we're bleeding out of. There's lots of opportunities, but we can't even afford what we've currently got. So it is a real challenge, but I don't disagree with you.
So I'm a bit conscious of time now. So are there any more points specifically on that? Because I don't think we've answered your question, Joe, have we? So just a couple more comments on that, and then we'll have to move on. And we've got a couple of AOBs, and we will finish by 12. It's my first chance to chair, and I'm not going to fail that. So Adam first.
Thank you, and echo brilliant presentation. So, I mean, in a way, I sort of challenge the premise of we haven't got enough money. Back to the initial presentation of if this is a priority and we're evidencing the outcomes, and I think in the report, it's one of the elements of the reports that really show when we do the check, the impact it has. It leads to a need that we then go into treatment. Why aren't we investing in it in whatever way across the system? And that's it's not just a conversation of public health, is it? That's how we work together. I think in terms of specific question around the champions, in a locality not far away from here, we've got 71 health champions voluntary working in the community who are doing this. They're going into barber shops, they're going into mosques, they're going into places where people are to do these sorts of checks. And I'm sure we're doing plenty of that in Trafford, but could do more. So I think there is an opportunity for champions to do that in the same way that there is in the workplace. I think it's the same scheme. And again, as partners in this board, the challenge should be back to us. What are we doing in our organisations to champion health? And I think we have the mechanisms to do it. And that doesn't necessarily require funding from a Trafford Public Health team. It just requires a commitment to do it in the organisations. And the organisations have a vested interest because, of course, it means our staff are well.
Yeah, it's a final point on this, and then I'll try and summarise. I don't know how I'm going to do that, but I'll try. So Richard, is your hand up as well, Bernadette? Yeah. Okay, you're Bernadette and then Richard, and then we will move on.
Thanks, really. Just a small point on the slide that refers to the Health and Communities project, and it was 114 NHS checks between matches. That's now over 300 to welcoming towards the end of the year, so it's just really smashed the targets that we set out in the first place. But I think what we're trying to do is use funds that we get to support what we know is working. But what we know is working is kind of because Dr. Burke can see it in her surgery on a day-to-day basis. And the challenge is, how do we actually articulate what's working and the savings that it's caused, that service, that project particularly in Sale is doing. So it's that evaluation work again. There's that gut feeling. So where you've got Dr. Ryland, you've got Dr. Burke, you've got these GPs that are really on board and really see it with their own eyes. It's how you kind of get that across. And there's also, it came up with North Trafford, that there's a challenge and there's nothing we can do about it in this room. There's the GP industrial kind of action sort of thing. So it's quite hard to get that innovation and change and that kind of new ways of working through at the moment. But, you know, where there's a will, there's a way, really, isn't there? But I think funding-wise, it's sort of when there is opportunities for funding, it's being creative and thinking, how can we use this? So multiple disadvantage is contributing to health and communities and sales to keep that going till December. But it's all, like I said in the first place, it's all piecemeal. It's all patch funding.
Thanks, Bernadette. Richard, thank you.
So I think the challenge, when we talk about health of the nation, we then try to fix it by looking at the NHS.
And I think we get very confused between the two things in this country. And when I look at the skills and competencies required to do a health check, it's the great advantage of having council Wi-Fi. You don't need to be an NHS practitioner to do it. It looks really straightforward to me. So I think we need to really look at how we do this. Why aren't we asking employers through social value and other things, what's the support we can give to the community sector to undertake this work for us? Why is there a cost attached? Because a band 6 nurse spending some time doing this must be really expensive. And I don't think you need to be that. So I think we should really look at how we address the problem. That will be my take on it. And I think it's entirely reasonable to be expecting people we contract with through staff, for example, to be doing this work as part of the social value. And then another point very quickly, which I'm going to sneak in, is this is brilliant. It's an amazing presentation, great example of joint working. And I'm not surprised because I know all the people involved are fabulous. I think there's also a challenge for us about this is the people we know who've got to this point. And I think there's something for us to think about growth and our growth strategy and how much of that is predicated on outlets that are selling ultra-processed food, alcohol, all of those things. It's just so easy to get hold of vaping. And I know we've talked about that before. So I think as a place, we have to rethink what we see as leisure in Trafford as well. And I'm not talking about your services, I'm talking about leisure opportunities overall. So that would be the other point I'd make very quickly, which was sneaked in, Gareth, but I'm going to stop now.
Yeah, thank you. I'm sorry about the look I gave you. So I think there's huge support for this, Joe, isn't there? I think there's a real feeling around the table is that yes, some targeting is needed, to target the need, but I think it needs to be one of our key priorities in our sustainability plan. So I know it's not a formal decision for you here in terms of how we're going to move forward, but I think we should be taking it back to decision-making forum to say that, you know, we don't want to reduce the amount we spend on this because, well, for the obvious reasons, and what Richard has suggested, and there are more sort of different ways we can do this as well, not just through the, you know, traditional, you know, GP route as well. So I know it's not answered all of your questions, but I think there's, you know, something to work on there at least. Yeah, okay. So just for a couple more minutes, has anyone got any other questions for any of the other colleagues who presented? Jane, come back to you. Yeah.
I was making a few notes as you were speaking, so just some specific questions really. The first one's been covered by Councillor Butt, which was looking at, you know, the populations maybe in the south of the borough. I was thinking of Broomwood, where there are pockets of deprivation. The second one was looking at the medications for obesity, because they have got really good outcomes. I know from working in diabetes, often the people who needed those medications couldn't get hold of them because they were so widely used for obesity. But I know that people can access those privately and there are issues in the supply chain, but they are really, really effective. And I'm wondering, are there any programs around working alongside the lifestyle changes that people, sometimes that medication can just get them in the right direction to start with? That's one point. And the other one was about young people. That was referred to in the very first presentation, about some conditions are increasing in young people. I think it's bowel cancer is increasing in young people, and also mental health challenges are increasing in young people. So those things that are kind of storing up along the line of those young people. And I think those are my main points.
Just to pick up on the medication and obesity, I think that's probably something, Helen, that we may need to take back to one of our colleagues who works in weight management and just see whether... Oh, do you, Alex? Sorry, I was thinking of Jane.
You're going to come in, Alex.
No, that's all right, quite all right. Yes, I completely agree, and it's a very important and public topic at the moment, isn't there? So I suppose just some assurance at the moment is there's huge NHS GM-wide programme looking at that at the moment. There's also been national guidance that have come out and been in the press, and it's very much looking about how we move forward as a Greater Manchester around our offers to people and ensuring that wraparound care is appropriate, because as you've mentioned, there's concerns around private and how we do that. So it's an area where demand is high and our capacity is low, but we're really looking at trying to remove that kind of postcode lottery element and having one sustainable approach as Greater Manchester. So I'm linked into that, and it's absolutely our view of bringing updates as we move forward, but there is an absolute active programme about making that more available and sustainable in the future. It's just going to take us a bit of time to work through that.
Yeah, great. Thanks, Alex. Just quickly then, Councillor Butt. Yeah. Oh, sorry, on the childhood
the young
well.
people, mental health and other health conditions, and the work in the south, are particularly asking about projects on the Broomwood.
So who's going to come back on those 2 points?
Broomwood is a pocket of deprivation in the Timpley area that's quite big, and yeah.
Yes, we'll bring Helen back in on that one.
So the challenge, not the challenge, that's not the right word, but one of the challenges with Broomwood is that the primary care offer is a Manchester offer, not a Trafford offer. So that's something we need to work with our Manchester colleagues around. But I know that Dan Shelston is doing a huge amount of work. There's a lot of activity around physical activity in Broomwood, so, and the community is really embracing all opportunities, I would say. But their healthcare offer is I'm looking at Kathy, is a challenge, isn't it, in terms of those cross-border workings?
Yeah, we are trying to work closely with Manchester colleagues, but everybody's got different budgets and different priorities. Obviously, we'll touch base with Manchester to see exactly what that offer looks like, because Helen's absolutely right. A really small proportion is actually covered by Trafford General Practice, as opposed to the middle of the line share is Manchester. So, I mean, we're all working to the same health agendas and we've got the same priorities. So we'll just touch base and see where the gaps potentially are and see how we can work together.
Right, thank you. I'm going to have to draw this to a close, sorry. So perhaps can we take an action for an update on the children and young people with cancer and mental health and bring something back to a future meeting? I'm sure that's reasonable to do if we take that. And I'm going to have to move on to any other business, I'm sorry. So thank you, colleagues, again. That is a fascinating discussion and a really good presentation. And we'll come back to that hopefully again and again, won't we? So we've got any other businesses. I'm not aware of any other, so I'm going to come to Helen for those 2 quick updates.
So don't get heartthink. Measles is circulating again in Greater Manchester, so please continue all the good work and messaging that you're doing around supporting our families and residents to get vaccinated. The GM pattern looks slightly different in that it's, I'm sure I'm describing this wrongly, older young people, so I suppose we're thinking about that 16 plus population and the younger adult group as well, where we're seeing the cases. There are none in Trafford, but some of the issues are around partial completion of vaccination. So any kind of messaging and support you can give. And for our community settings and healthcare settings, it's just about thinking measles if a patient does turn up with symptoms that link them. The second one is really good news and very hot off the press. So Neil Courtney, who's in our antisocial behaviour team, has messaged me today to say that they've closed a shop last night in Seymour Grove that was selling illicit tobacco, illicit cigarettes and illicit vapes. And he's literally just come out of the court now. He's very excited. He loves all of this, isn't he? Refers to the police as cops. He's very 1980s kind of, they're professionals, isn't he? But this is brilliant, really good news. And the shop will be closed for 3 months. But you know, there's lots of ongoing work there. And that's just also a testament to joint working. So we jointly fund a licensing officer out of the tobacco grant that works very closely with our regulatory team who are going in and checking these settings. So brilliant news.
Yeah, thanks, Helen. That put a smile on everyone's face to end the meeting. Thank you. So I'm going to draw the meeting to a close. Thank you to presenters in particular, but to everyone for coming to the meeting and for the comments. It's been a really good discussion, actually, hasn't it? So thank you. And our next meeting is on Friday, the 16th of May, at the same time. Yeah, I think you should come to that one.
Oh, stop it. Just figure that out.